Our guest for March, Dr. Eric Bricker. Welcome back, Dr. Bricker.
Hey, Heath, thank you for having me.
Yeah, well, thank you. We got a good audience following you over here, so I appreciate it. And we're going to be talking about the healthcare inflation and what's fueling that fire. I think this can be a good one. Dr. Bricker, always entertaining. Appreciate having you on board. And Lindsay, if you want to go to a next slide, we can let everybody read about Dr. Bricker, but I'm sure the vast majority of you are very familiar with his YouTube, chats and whiteboard postings and all the things he's got going on. Heck, we had Mark Cuban on last month, so congratulations to you getting that audience. That's fantastic. And anyways, we I'm going to turn it over to you, let you drive this thing, and let's get the conversation started.
Wonderful. Well, again, thank you to everyone. I saw lots of familiar names in the attendee list, so welcome to all of you. And for the folks who I don't know you and you don't know me, welcome as well. And just a real quick background about myself. So I'm Dr. Eric Bricker. I'm an internist. Did my training at the University of Illinois and then residency at Johns Hopkins in Baltimore for internal medicine. I founded a healthcare navigation company called Compass Professional Health Services, which grew to about 2,000 employer clients, about 1.8 million people. And I kind of jokingly say that when you help 1.8 million people navigate the US healthcare system for 11 years, you learn a thing or two. And so I started making these AHealthcareZ videos because I was actually the guy outside of the office meeting, doing sales and marketing and account management, meeting with all the employers and the broker consultants, working with them. And I had seen, I'm not trying to be disparaging, but there's a little bit of sausage making that goes on. And so when we sold Compass, I then didn't have a boss anymore. And I'm like, I can kind of shoot people straight and kind of let them know sort of what I've learned over time. And believe it or not, like millions of people watch these AHealthcareZ healthcare finance videos. I'm like shocked. It's a rather dry topic. I try to make it as exciting as possible. And so next slide, please. I'd say that the topic for today is the hidden cause for healthcare cost inflation, and I'm going to talk about this hidden cause in the form of sort of six punchlines. And punchline, so I'm just going to give them to you now, and then you're going to see them again through the rest of the presentation. So punchline number one is hospitals are the main cost driver for employer-sponsored plans. Labor is the main cost driver for those hospitals. Insurance carriers negotiate low payments for Medicare Advantage and high payments for employers. So, we're going to actually talk a lot about Medicare Advantage today. So, even though you're like, oh, I work in employer-sponsored health plans, I don't need to know about Medicare Advantage. You actually need to know a ton about Medicare Advantage. And I'm going to teach that to you today. And so, because frankly, insurance carriers make a lot more money on their Medicare Advantage than they do on their employer plans. So, um, Medicare Advantage is hot and employers are not if you're an insurance CEO. And so keep in mind these insurance carriers are interacting with not-for-profit hospitals that actually make as much profit as for-profit hospitals at the employer's expense. And all of this is done in an environment, punchline number six, where there's very little competition in the marketplace. But it's not all doom and gloom. There are strategies that employers can use to help themselves. So we're not just going to talk about problems today. We're going to talk about solutions as well. So there you go. Next slide. So now we're going to go through each one of those punchlines in detail. And to Heath's point, please put your questions in as I'm talking, and then we will go through all of them at the end. So I'm a big Steve Covey fan from, Seven Habits of Highly Effective People. You've probably heard of him and heard of that book before. And one of his quotes that I like is the main thing is to keep the main thing the main thing. So it's very easy in healthcare and health insurance and employee benefits to get distracted. But when it comes to healthcare cost, the main thing is hospital services. So if you want to cause trend deflection, if you want to decrease your trend and decrease healthcare cost inflation, you must address hospital services because hospital services are over 45% of the overall cost for employers. Now, keep in mind, that's not just inpatient services. The majority of hospital services these days are actually done on an outpatient basis. So when I say hospital services, that means hospital systems providing both inpatient and outpatient services to plan members. Then the second largest bucket is professional service. So the docs, the physical therapist, the occupational therapist, the respiratory therapist, et cetera, et cetera. Professional services is 31%. And then prescription drugs, 23%. I mean, yes, prescription drugs is rapidly growing, but at the end of the day, you can knock your prescription drug cost way down and still have a healthcare cost problem if you have not done something about your hospital cost problem. Okay? Next slide, please. So then the question becomes, well, why are hospital costs so high? So the overall cost, the healthcare cost equation, I'm sure all of you are very familiar with this. The healthcare cost equation is very simple. It's just price times quantity. It's the price of an MRI times the number of MRIs. It's the price of a CT scan times the number of CT scans. It's the price of a surgery times the number of surgeries, right? So the question then becomes, if hospital costs are high, is it because the prices are high? Is it because the quantity is high? Or is it because of both? And so what you can see here in the graph is that from 2018 through 2022 is the increase in cost versus utilization versus price. And so costs overall are up 19% over that time period. But that 19% is made up of 14% increases in prices and only about 4% increase in utilization. So overall, hospital costs are not going up because our plan members are using hospital services so much more than they used to. This specifically is a pricing issue. So it's because hospitals are increasing prices. And hospitals increasing prices is not some sort of like magical force of nature. Like hospital prices rise because literally there is a person named Mary or Steve or Linda or Joe, right? Somebody is like literally making the decision to raise those prices. So just know that these rising prices from hospitals is due to a conscious decision by individuals within those hospitals to make those price increases. And obviously, they've done the calculus on their end. They know that if they increase the prices, that they're not going to lose patients, that they're not going to lose utilization. So here we have an environment where hospitals are almost, they almost have an unlimited possibility of increasing prices because it does not decrease their patient flow. Next slide, please. Okay, so punchline number one, employer healthcare costs are rising mostly because hospital systems are raising prices. I'll say, so don't get distracted with all this other stuff that you might hear. Well, it's because of this or it's because of that. An employer health plan spend, by and large, is going up because hospital systems are increasing their prices. And I'm sure all of you in your minds are asking yourself this question. But I hear in the news that hospitals are struggling financially. If employers are paying hospitals more, then why are they struggling? Next slide, please. I think that's an excellent question. So then we got to look at, okay, well, what are the hospital's own underlying costs? What do hospitals have to spend their money on? And this pie chart here shows what hospitals spend their money on. By far, the largest cost component for hospitals is labor. It's for the nurses and the techs and the orderlies and the physicians, if they have physicians on staff, and the administration. So believe it or not, the number of employees at a hospital that are patient facing is actually smaller than the number of employees at a hospital that are not patient facing. In other words, the majority of employees at a hospital system actually do not interact with patients. All right. Now you've got 13% on supplies, 8% on drugs, and then others a pretty big category. It's 19%. What is that? One, it's their electronic health record. It's software. So I'm sure all of you have heard of Epic before. But when a hospital system puts in an Epic EHR system, it's like over $1 billion. Okay, so like the healthcare software is hugely expensive. And then hospitals themselves have to pay for malpractice insurance, et cetera. Okay, so just know that when employer healthcare costs are going up and they're going to hospitals, essentially what employers are a healthcare jobs program for mostly non-patient care people, i.e., administrators. So essentially, you, as an employer sponsored plan, are paying for the jobs of hospital administrators. You're paying for more administrators, you're paying for increased salaries for administrators. So you're like, okay, well, who's getting the money? Okay, like hospital administrators are not like waving a flag saying, look how much money we're making, look how, blah, blah, blah. Like they don't do that, right? Typically, the people who are making the most money, they keep quiet about it. All right. So just know, and believe me, this has been a, 6 degrees is located in the Pacific Northwest. Many of you are not, but believe me, the salaries and the income of hospital executives in the Pacific Northwest has been all over the news, and it is quite a point of contention. So people are starting to be aware of where this money is going. Next slide, please. Okay, so hospital and this labor cost has been going up, right? So ever since COVID, it's been going. Actually, for the last 10 years, it's been going up, right? So hospital labor inflation is up 45% in the last 10 years, whereas overall inflation is only up 28.7% in the past 10 years. So in other words, healthcare labor costs are rising 57% faster than overall inflation. And so, if you have a hospital system that is crying poor and saying that they don't have enough money, it's because they're paying out a lot of money in terms of labor costs, much of the time in terms of administration. Okay, when was the last time you've heard of a hospital doing downsizing of their administration? Almost never. Okay, next slide, please. So, hospital punchline number two, hospitals costs are up because labor costs are up. And again, I'm sure many of you are asking yourselves, but I walk into a hospital and it's filled with seniors and not people that look like my employees. Isn't Medicare paying for most of this increased cost? And I would encourage you, like, literally do this one day. Like, if you just happen to have a spare couple of hours, just go to the lobby or to the waiting room of like a hospital or like an outpatient clinic across the street from the hospital and just look who's there. Look who's there. It's old people. That's who's there. The vast majority of the greatest risk factor for health problems is age, right? So the vast majority of people are old. Next slide, please. So let's look at a hospital's revenue by payer source. So with all those old people, about 40% of hospital revenue comes from Medicare. And about employer-sponsored health plans also make up about 40% of a hospital's revenue. Medicaid makes up about 10%. And then ACA, what are sometimes called Obamacare plans for individuals on the exchange, they're about 5%. And then self-pay is about 5% of overall hospital revenue. Now, the kicker on the Medicare piece is that Medicare is actually broken up into two different types of Medicare. About 45% of seniors on Medicare are on traditional Medicare, and about 55% of seniors that are on Medicare get their Medicare through an insurance company. In other words, they're on a Medicare Advantage plan. And that 55% of seniors on a Medicare Advantage plan is by far the biggest force in health insurance today. Okay, so the biggest movement in healthcare, the most impactful force is not employer sponsored health plans. It is Medicare Advantage. Next slide, please. So let's talk about how much each of those payers then pay the hospital. And let's benchmark it against traditional Medicare. So let's just call traditional Medicare at 100%. Well, look at this. Medicare Advantage actually pays less than traditional Medicare. It only pays about 90% of what traditional Medicare pays. Why is that? Is it because the insurance carriers negotiate rates that are less than Medicare rates with hospitals? The answer is no. the allowed amount that Blue Cross United, Cigna, Aetna, or Kaiser or whomever is negotiating with a hospital system, it's about the same as the Medicare rate. But what does Medicare Advantage have that traditional Medicare doesn't have? It has prior authorizations and denials. I mean, if you bill traditional Medicare, guess what? Medicare pays pretty quickly, actually. And so just all of the denials from the prior authorizations and from the slowness of being paid by the health insurance company on Medicare Advantage plans, most hospitals take at least a 10 percentage point haircut off of their overall reimbursement from Medicare Advantage plans because of all that administrative mumbo jumbo that goes along with a Medicare Advantage beneficiary vis-a-vis a traditional Medicare beneficiary. So hospitals have essentially seen their Medicare revenue go down because the Medicare Advantage population has grown so much over the past 10 years. Employer, and look at this. Of course, all of you know this. This is not new news, but I'm going to highlight it anyway. Employer-sponsored insurance plans pay on average 254% of Medicare. I would argue, and that's the Rand study data. I would argue, because I've looked at the data that Rand looked at, in my opinion, I think Rand underestimates that amount. I actually think it's closer to 300 to 400% of Medicare. And I believe me, I've looked at employer-sponsored claims from self-funded plans for a long time. And when I visually look at the claims, it also looks to be much higher than 254%. Like I think it's really closer to 300 or 400%. Again, on average. Look at this. Medicaid pays even less. It's 70% of Medicare. And then ACA Obamacare plans, they do pay more. They pay about 200% of Medicare, but it's not a ton of patients. And then I put self-pay at 20% because frankly, self-pay means no pay. So a lot of patients, they just don't pay at all. And so, yeah, you get some patients paying cash, but a lot of patients that don't have insurance, especially in states that haven't expanded Medicaid, self-pay oftentimes just gets written off to bad debt. So it's about 20%. Next slide, please. So punchline number three, insurance carriers are negotiating two different prices with the same hospital system at the same time. So in Blue Cross United, Cigna, Aetna, whatever network you're talking about, when they go and negotiate with the hospital, they're not negotiating the Medicare Advantage rate and the commercial rate with like different people at different times. Like they're doing it all together at the same time. And the employer price is like 150 to 600% higher than the Medicare price. And so again, immediately all of you are asking yourselves, but why would an insurance carrier do that? Why would they give away the farm on the employer pricing? Next slide, please. So what I'm going to do, oh, maybe it's a couple slides from now. So before we go any further, let me talk about the growth of the Medicare Advantage gorilla, okay? Medicare Advantage is up 32% in the past 10 years. Up from 32% 10 years ago to now it's 55%. And it's expected to be 71% of all Medicare beneficiaries in the next 10 years. Why are so many people signing up for Medicare Advantage? Because there's oftentimes low or no premium to sign up for a Medicare Advantage plan, and it offers lower out-of-pocket costs. It's only co-pays. So traditional Medicare, you've got a deductible to go into the hospital, and you got to pay 20% co-insurance for all outpatient services, which ends up being a lot. Plus, Medicare Advantage has dental, vision, and hearing aid coverage. So traditional Medicare has no has no dental vision or hearing aids. So shoot, the insurance carriers, they even give people like $500 gift cards to the grocery store for signing up on a Medicare Advantage plan. So everybody's like, oh, this is fantastic. Why would I ever go with traditional Medicare? When I get dental and vision, I get my hearing aids paid for. It's only $5 copays to go to the doc. Okay. The profit margin for an insurance carrier on Medicare Advantage is twice as much as the profit margin for an employer sponsored plan member. So the average profit margin for a Medicare Advantage plan is $1,600 per member per year. For an employer sponsored health plan, it's only $800 per year. So not only is Medicare Advantage a faster growing business segment than employer sponsored plans, it is a more profitable business segment than employer sponsored plans. So if you're an insurance carrier CEO, the financial future of your company is not with employer sponsored plans, it's with Medicare Advantage. And if you listen to the uh, quarterly earnings calls of all the major carriers, all they do is talk about their government plans. And all the analysts on Wall Street ask about is the government plans. They don't talk about employer sponsored plans at all. I would listen to these earnings calls. I'm like, when are they going to talk about employer sponsored plans? They never talk about it because it's financially irrelevant. It's not the future of the industry. How do you know that? All the insurance carriers' stock prices have crashed over the past 3 to 6 months. Why is that? Because Medicare Advantage redetermined how they were going to pay insurance carriers. It's because the floor fell out of the Medicare Advantage market. That's why the stock price is tanked because they know that all the value of an insurance carrier is in Medicare Advantage, right? And they're not all created equal, right? So United is the 8,000 pound gorilla. They have 29% of all the Medicare Advantage beneficiaries. Humana's got 18%. Humana's unique in that they don't do employer sponsored plans. They only do government plans. But United obviously does a ton of employer sponsored plans. Listen, Anthem and all the Blue Cross Blue Shield plans, they do 14%. Aetna and Kaiser, Centene make up 23%, and then 16% other. Next slide, please. So now let me take you to the negotiating table between the insurance carrier and the hospital. And so this is where, and they only do this about every 3 to 5 years. The hospital says, look, you just need to pay us about $500 million a year. So note that the hospital is just looking for an aggregate number. They're like, look, to be in network with us, and that's like a relatively small hospital system. Like larger hospital systems, they'll sit down with Blue Cross and they'll just be like, Blue Cross, look, you just need to pay us like $6 billion next year. How are we going to get the $6 billion? To be in network, $6 billion. United comes in the door. United, to be in network with us, you just kind of need to pay us $3 billion. Like, how are we going to get to that $3 billion, right? So they're really looking at these large aggregate numbers. That's what they're looking at. And the insurance carrier comes back and says, look, we need our Medicare allowed amounts to be low, like Medicare low. And the hospital's like, fine, like, but then you need to give us something somewhere else so that we can get to that $6 billion. And so the insurance carrier says, okay, well, we'll pay you a lot more for our employer sponsored plans because one, we're not taking the risk on them for our self-funded folks. And then two, like if healthcare costs go up on our fully insured book, like actually that's good for us because that just means that we can increase premiums and we kind of want that to happen anyway. So the hospitals, I kind of liken it to like that 80s movie Joe versus the volcano, where like Tom Hanks was gonna like sacrifice himself to the volcano, right? It's like in order to keep the hospital volcano happy, then the employer Tom Hanks has to be sacrificed to them. So that's what's happening to your employer sponsored plans. That's why everybody's like, but Blue Cross and United, they're so big and powerful. They should be able to negotiate better rates for us. They negotiate better rates for their Medicare Advantage beneficiaries, not for you. So that's where they're using their negotiating leverage. It's for Medicare Advantage. Next slide, please. Punchline number four, insurance carriers sacrifice self-funded lives where they're not taking any risk and fully insured lives because they need an excuse to increase the premium because of the MLR restriction to maintain high margin on their growing Medicare Advantage lives. And of course, all of you are asking yourselves, but why in the world would an insurance carrier do that? Why would they give away the farm on the employer pricing? Next slide, please. Okay. Excellent question. And it's because, again, they're keeping the volcano happy, right? And the volcano are these hospital systems. And you're like, but these hospital systems are not for profit. Like, why are these hospital systems like turning the screws so hard? And so, what we're looking at here is the operating margin for the most quote unquote profitable hospitals in America. Okay. So, the most profitable hospital in America for, I think this is 2024, was Tenet. Okay. And their profit margin was 14.7%. Okay. Um, Piedmont was number two at 13.1%. Piedmont is not for profit. Advent Health is number three at 11%. Universal Health Services is for profit at 9.5. But look at this in Dallas, Baylor Scott and White 9.4, and then all these other guys, Mayo, Stanford, Colorado, Penn, Novant, University of California, they all are not for profit. And then look at this HCA, the largest for profit hospital system in America, is only at 4.7%. So the point is that these quote unquote not for profit hospitals are more profitable than the largest for profit hospital system in America. Now, because they are not for profit hospitals, they don't call it profit. What do they call it? They call it excess revenue. They have too much revenue. It's excess. Believe me, they hold on to it. So the excess revenue rate for Piedmont Healthcare, that's down in Georgia, 13%. Okay. The excess revenue for Dallas, in Dallas from Baylor Scott and White, 9.4%. Okay. So being profit or not profit is really a taxation status and whether or not you can offer shares. Okay. That's all it is. In terms of the actual financial motivation of the hospital, it is no different between a for profit and a not for profit hospital. Next slide, please. Punchline number five, hospital systems and health insurance carriers work together to shift rising costs to employers, growing margins at employers and employees' expenses. Okay. So basically, the biggest way that you can see the failure of employer sponsored health insurance in America is that 20 plus years ago, employer sponsored plans used to cover dependents. And now they almost never do. If you have a family of four and you're the employee and you want to put your spouse and your two kids on the plan, you're paying the premium for that spouse and for those two kids. Why? Because the employer just can't afford to pay for them anymore. So essentially, the biggest way, it's not the most recent way, but the biggest way that employers have quote unquote cut the cost of healthcare for their health plan is just to not cover people. And they guess what? They're continuing to not cover people. I'm sure many of you are familiar with this. There are vendors out there now that will set up HRA plans to actually pay employees to go on their spouse's plan and not stay on their own company's plan. So basically, it's a game of hot potato where many employers, their quote unquote cost containment strategy is let's just not have people on our plan. Okay, doesn't sound like a very, very viable strategy long term. Okay, so then all of you on this call, I'm sure, are saying to yourself, but I'm a capitalist. I believe in free markets. Why don't hospitals compete by lowering costs? And why don't health insurance companies compete by lowering costs, right? Like costs should come down because of competition. Ah, that's an excellent point. Next slide, please. So, believe it or not, there actually is an official measurement for market concentration and competition. And it's referred to as the Herfindahl-Hirschman Index, which is hard to say, which is why it's just abbreviated the HHI. And I graduated with honors with a degree in economics from Northwestern University, which means I know just enough to be dangerous when talking about the HHI. And so on the scale, a particular market, it could be a market for hospital systems, it could be a market for restaurants, it could be a market for software services. The market is considered unconcentrated when the HHI is less than 1,500. Unconcentrated means there's lots of competition. So like for restaurants, right? There's tons of competition for restaurants, right? So the HHI for restaurants in your town is probably less than 1,500. Now, moderately concentrated is 1,500 to 2,500. Highly concentrated is 2,500 to 4,000. And extremely concentrated is greater than 4,000. Okay, that's the scale. Next slide, please. Let's take a look at hospital system concentrated. 97% of markets in America are considered highly concentrated. In fact, 47% of metropolitan statistical areas are controlled by one or only two hospitals. And in fact, 19 markets have a single hospital monopoly. One example is Indianapolis, where it is 1,800. There is, if you go to the link on here, that first source there, you can actually see it has a map and it shows the HHI by metropolitan area. I'm sure you can have the slides afterwards. And so it's fascinating to be able to look at the HHIs and all the different markets. So in other words, there's not a lot of hospital competition, period. Next slide, please. Let's look at health insurance carriers. Again, 97% of the markets are highly concentrated. The mean HHI across all metropolitan statistical areas in America is 3,485. And remember, greater than 4,000 is extreme. So 34 of 85 isn't too far off, right? So even for health insurance carriers, it is highly concentrated. Blue Cross Blue Shield dominates in 84% of the MSAs, and UHC is number one or number two in most markets nationally. So, yes, competition would bring down prices. The problem is there is no competition. Next slide, please. So that's punchline number six. Capitalism without competition is exploitation. Competition is deflationary. Monopolies and oligopolies are inflationary. And at this point, I'm going to stop because I'm sure enough of you are like, enough already, stop with the problems. It was like, oh, healthcare. It's always so depressing whenever I hear about this healthcare stuff. Okay, give me some solutions. Okay, next slide, please. This is what actual high performing employers are doing when it comes to their health plan. And it specifically in relates to the healthcare supply chain. And this is what actually the head of HR at International Paper, he did a great interview that you can watch online. He said employers have achieved trend deflection by breaking down and rebuilding the healthcare supply chain. So really top performing employers have realized that their healthcare supply chain is broken and they really look at solving their healthcare cost problem like they would solve any other supply chain problem. Which guess what? International Paper is really good at managing supply chains. Like that's what they do to like run their business. And so interestingly, um, we're going to need to then in this talk break down and rebuild the healthcare supply chain. And as you can imagine, that's no quick fix. So the short answer is sorry, there is no quick fix. Next slide, please. So here is the healthcare supply chain, okay? And the supply chain is actually in the blue, okay? Where you've got the patient in the top left, and you've got the health plan actually cutting the checks down in the bottom middle. And then you've got all the steps in the supply chain in between. So let's go from the plan and work our way backwards. So before the check is cut, the claim actually has to be adjudicated. And before the claim is finally adjudicated, it has to go through network repricing. In other words, where the discount is applied off of billed charges. And then before that, then you actually have to have like hospital systems providing services. And then the level before that is you have kind of less intense outpatient provider services. And then you actually have patient. So here you've got one, two, three, four, five, six levels in the medical supply chain. And astute employers actually look at each one of those six levels. And there are specific things you can do within each of those levels to fix your supply chain. And we're going to start with the plan itself. So the problem is that there's really a staff and a skills mismatch to run the plan. Most employee health plans, the employer has dramatically underinvested in the people at the company to actually run the plan. And I'm sure many of you have seen this, where there's health plans that have hundreds of millions of dollars of spend every year. And then they've got like two people running that plan. And then they have people who, frankly, are not really skilled or trained or even qualified to do that. And so, really, and the Purchasers Business Group on Health, which used to be the Pacific Business Group on Health, has a fantastic framework around investing in the benefits team where it outlines the specific skill sets that people on the it's like a checklist that the people on the benefits team need to have. And so frankly, companies that invest in increasing the size of their staff and increasing the skill of their staff, they end up spending more in fixed cost on their plan, but the overall decrease in claims cost more than makes up for that investment. One of the examples that I'm going to show you is Purdue University, which has kept their trend at like 1% for many years. Like they have 26 people on their benefits team. Okay. Now, granted, they've got like 40,000 employees, but most companies with 40,000 employees do not have 26 people on their benefits team. And guess what? Their total spend, including those 26 people's salary, is far lower than all of their peers. How do you know that? Did you know that Purdue hasn't increased their tuition in like over 10 years? It's like over 15 years. Purdue is actually famous nationally for having some of the lowest in-state tuition in the country. They have not increased their tuition at all. Why? In part because their healthcare costs for their own employees has not gone up. What a tremendous value for the students of Purdue University that frankly their college tuition is much less because their employee benefits team does such a great job. Okay, fine. Claims adjudication, pre-pay audits. So the highest performing organizations are finding fraud and abuse, but they're doing it on a pre-pay basis. In other words, they're stopping payment before the claim is paid, which historically could not be done with a major BUCA carrier because they would just pay out the claim, pay, 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 pay. And then the employer is forced to do what's called pay and chase. So if you find a fraudulent claim or a claim that was paid in error, I mean, I've looked at claims for years. I literally, within the past 6 months, saw a self-funded employer in California get billed by the University of California at San Francisco for $450,000 for the exact same patient on the exact same date of service twice. And the plan paid it twice. The plan just paid an extra $500,000. Like you don't need AI to figure that out. Okay. It's the exact same patient on the exact same day. They just sent the bill over twice and it was paid twice. What a great plan. Every hospital in America should just bill the same patient twice. And they'll just get paid twice. You want to double your revenue? Just send twice as many bills. Because apparently the carriers pay those. Okay. I was just talking with another broker for their group. They had United pay $25,000 against their plan for a member that was not even on their plan. He was on a different plan. Again, like you don't need AI to figure that out. Like, okay, like yeah, that person needed to pay $25,000, but like that person's like not even on our plan. Like, what did you do? Okay, next for the network repricing. Go back for a second. Okay. So this is where employers are either engaging in their own direct contracts that are about 130 to 150. Shoot, sometimes they're 200% of Medicare, and it's still a lot less. In other words, employers through direct contracting can get a much better deal than what the carriers are getting. Um, Finally, going back to hospital services, this is where best practices employers are steering within the network to higher value specialists, lower cost specialists that are of higher quality. If you, d- I say to plans, the plan members are getting steered. It's just a question of by whom, because the hospitals have very intentional referral strategies to steer patients, frankly, to their highest costing service lines. So just know that if you as an employer are not doing anything, your plan members are being steered by hospitals to spend as much of your money as possible. And so you as an employer need to counter that with steerage solutions. And one of the foundations for those steerage solutions is the next level up, which is advanced primary care, that all of the best practicing employers are putting in some type of advanced primary care strategy. It can be on-site, near-site, direct primary care. It can be a combination of bricks and mortar and virtual. It can be 100% virtual. But if you as an employer don't have an advanced primary care strategy, you're essentially being left behind because all the other employers that actually have high functioning health plans, they're doing that. And you use the primary care strategy as the basis for your steerage strategy. So don't think you're going to be able to steer people through a prior authorization process like that. The train has left the station. It's too late. That is a highly unsuccessful approach. Yeah, you might get 3% of people to do it, but it's too late. You have to catch them earlier in their care journey when they are initially symptomatic, which is why you have to engage with primary care. And then lastly, you're doing all of this in an environment of high disease burden within the employee population. And the main cause of that high disease burden within the employee population is metabolic disease. It's metabolic dysfunction. Believe it or not, metabolic dysfunction not only increases cardiovascular disease and not only causes musculoskeletal claims because of excess weight, it also causes cancer because obesity and insulin resistance are actually carcinogenic. Okay. So, obesity and insulin resistance are risk factors for breast cancer. It's a risk factor for colon cancer. It's a risk factor for pancreatic cancer. It's a risk factor for kidney cancer. So, if you're going to do anything about the disease burden within your employee population, then metabolic dysfunction is where it needs to happen. Next slide, please. So
Okay,
he, so
Dr.
again,
Burger,
yeah,
there's a question that comes in or came in. I don't know if you want to address it
no, it's
on
okay.
that last slide set. Okay. And it kind of falls into that network relationship component there, but it reads, if hospitals are negotiating at bulk and the BUCAs are shifting the cost to employer plans, are you saying that the hospital is perfectly willing to accept a lower price from an RBP vendor, a direct contract, or a small narrow network because they aren't starting from a point of accepting Medicare Advantage in that in the offsetting? I've never thought of it that way regarding Medicare Advantage. I've always just thought of a quicker payment or maybe less red tape, but it seems like the lack of Medicare Advantage might drive the mindset of accepting a lower cost since the net is still far greater than 100% of Medicare. And it goes on there. But your thoughts on
Yeah,
that?
no, that's 100% correct. Essentially, when an employer is offering a direct contract, what they are offering is faster payment. And that faster payment can be on the data service. It can be within 30 days of service. But there are many hospital systems and many ambulatory surgery centers and many imaging centers that would be more than happy to take 150% of Medicare if they can get paid on the same day or within 30 days than having to deal with the shenanigans of the carrier. 100%. Will all hospital systems do it? No, you don't need all hospital systems. But can you have direct contracts? And then what you do is you steer the employees to those direct contracts by saying, look, if you use a direct contract, it's zero out of pocket for the employee. If you use the direct primary care or the on-site or the near-site clinic, it's zero out of pocket. So you don't even have to do a gatekeeper HMO model. You're just like, look, in our ecosystem of primary care and direct contracting, if you use it, zero out of pocket cost. If you still use the traditional carrier route, it's deductible coinsurance, copays, yada, yada, yada. And you can get effective steerage through that mechanism. That's what Purdue did. That's what Serigraph did. That's what BevCap did. That's what Lincoln National Bank did. And the reason that I bring up these other examples here is because one, Serigraph, they literally wrote the book. Many of you guys know this book. So if you do anything, you've got to read the company that solved healthcare. It's basically malpractice if you work in employee benefits and haven't read this book. Okay. And then BevCap, people are like, well, my employees are, low education and it's a bunch of guys and they're knuckle dragging, Neanderthals, blah, blah, blah. Like, look, BevCap did this with a bunch of beer truck drivers and they've kept healthcare cost trend flat for 10 years with beer truck drivers. Okay. And then some employers are like, yeah, that only works if you're a Fortune 50 or a Fortune 500 company. We're just a small employer. We can't do this. Look, Lincoln National Bank in Kentucky cut their healthcare spend by 50% just through direct contracting and they got 115 employees. So there literally is no excuse that an employer can make that says that it can't work for them because I've literally seen it in every single environment. There is not an employer out there that cannot effectively put in one of these strategies. And the point is that you don't have to change all of six things in the supply chain all at once, but you do need to start somewhere. And you start with one, and then you move to another, and then you move to another. But there's not an employer out there that can't do that. Next slide, please. So that's it. And I really appreciate all of you listening. And I would like to pause for whatever questions or comments that you would like to add here.
Yeah. Well, there's a couple things that I was thinking of as you were going through there. One was kind of a carryover from Bud's question and the prompt payment or quick payment, and we built our Medicash solution into our RBP product. So obviously, reference-based pricing does a phenomenal job at cutting costs. But with that, you have to have different levers to pull to make sure that it works for that employee in a certain market. Not everything's easy, which is the rub you get with RBP. But one of the things we built was that Medicash solution, and it's been very successful at getting people past some of the access issues or balance bill resolutions and just getting people paid quickly. And as you pointed out, systems are quite eager to get paid, and that helps alleviate some of that. So.
100%.
A question came in here from an anonymous attendee. What are your thoughts on universal healthcare?
Oh, in my opinion, it won't happen in my lifetime. I'm 49, so maybe after my lifetime. But there are too many, without getting into the details, in my opinion, there are too many political hurdles that get in the way of that ever happening. One, the biggest opponent to universal healthcare are literally the hospital systems themselves. And those hospitals, and many of you know this, but the number one employer in most states in America is healthcare, specifically the hospital systems. And so the hospital systems are very powerful, not because of their lobbyists in Washington, but because of their voter base. And so I think it's highly unlikely that you will ever get single payer or national healthcare because the hospital systems won't let it happen.
With that in mind, I'm kind of curious, and I don't want to put you in a spot where you're recorded here and you're held to it, but I'm kind of curious what you foresee as being some of the big milestones that are coming. 1 year out, 5 years out, 10 years out. Any predictions and what to see in the world we live in for healthcare?
Yeah, how any sort of change in healthcare is hugely countercyclical with the performance of the economy. And so we saw that during the Great Financial Crisis from 2007 to 2009, where pre Great Financial Crisis, HSA, Consumer Directed Health Plan adoption was like 3% of plan members. And then there was a crisis where employer revenue went down because of the recession, and that caused the pain necessary to make changes to the plan. And so we saw, consumer directed health plans go to about 33, 34, 35%. They kind of maxed out there, right? It wasn't the end all be all solution, but that was a significant shift in the employer market. What have you seen between then and now? Almost nothing. There have been no dramatic changes in employer sponsored health plans, and especially since COVID. Like nothing happened during COVID. And then since COVID, there's really been a ton of employer atrophy, or excuse me, apathy. Many broker consultants are trying to get their employer customers to make changes, and the employers won't do it. They refuse because essentially they're not dumb. They've made the calculus that the juice isn't worth the squeeze. They're like, yeah, I hate it. Yeah, it's expensive. Yeah, it goes up. But you know what? We're not doing that bad. So they complain, but they still keep writing the checks. And so I think you always see a change in the employee benefits landscape when you see a financial downturn. And so these financial downturns, they don't affect the country equally. Certain parts of the country will experience financial downturns more than other parts of the country, and they affect certain industries more so than they impact other industries. So it's not going to be even across the board. But if you want to look for a place where there's going to be change within employer-sponsored health plans, you look for a place where there are employers that are financially struggling, which interestingly, one of the places where employers really are struggling is with municipalities and school systems because they're having a really hard time increasing tax revenue. And so their healthcare costs continue to go up, but they can't increase their prices. They've got like a ceiling of their tax revenue. And so literally municipalities are having to like not hire police and fire and streets and sanitation workers, et cetera, because they literally are spending that money on their employee health plan. So if there I can't see the future. I have no crystal ball. But if there is going to be any sort of impetus for change, that typically is where it is.
Yeah, I'd agree. We've seen those trends. I will say this the last 12 months, last 18 months, definitely has been a surge in interest for reference-based pricing, and in some of the markets you just spoke about. But you're seeing some of these renewals coming back that are just unaffordable for plans, and they don't have any other options, and they make the jump for RVP. I think others look at it for some of the other reasons, the ability to build a plan on a chassis that they create. But we've definitely seen a spike in interest for RVP this last 18 months coming off the backside of COVID. Okay, here's another question that just came in. We got a few more minutes. Well, I haven't read this thing in full yet, so hopefully it's a question. We had an employer notice on a Regis billing and went to their TPA and asked why they were paying these charges. The TPA stated the provider contract allows for them to charge whatever they want. The plan cannot do anything about it. What do you recommend for the plan?
So, in the case of a provider charging whatever they want, it sounds like that was repriced through a contract term that was either a percent of charge discount or what is referred to as a provider stop loss, such that, which is not stop loss insurance, it has nothing to do with that, which is that once the billed charges exceed a specific threshold, they flip from a fixed case rate of like 6 grand to a percentage charge discount contract. And so to to that point, the issue is not the provider's billed charges. The issue is the contract term. And so that's specifically where the employer's like, oh, and you can see for it, it'll be for specific services. It'll be like for like orthopedic services or cardio, for like valve replacements in the heart, or maybe it's for putting a pacemaker in, what have you. And so that's where you would want to specifically look at your claims and see where you're getting dinged for that. And specifically, you might want to, because you don't need to direct contract for all services. Like when you direct contract, you could be like, look, I only want to direct contract for ortho, or I only want to direct contract for cardiovascular services. So you don't have to boil the direct contracting ocean. You can pick specific services, maybe where you're getting particularly shellacked by your existing network, and direct contract there.
Okay. We got a short statement with a question to follow. It seems that at 254% is way more than offsetting the 10% haircut on Medicare Advantage. Um, it seems if the hospitals should go out of business, either one, they have a very high Medicaid, or two, incompetent leadership. How much do you think it is incompetent leadership, and how do we address it?
Yeah, so it's a good question. There's no doubt that there are hospitals that are mismanaged. But they historically have always had a pressure valve or a release valve that they can use to address their financial woes, and that is their employer-sponsored reimbursement. And so that's where one of the best examples of a hospital turnaround was the Ochsner Health System in New Orleans, where they looked at their patient population and they're like, look, we just don't have a lot of employer-sponsored patients, period, because we have a mostly Medicare and Medicaid population in South Louisiana. And so we don't really even have employers that we can sock it to. They're like, we wish we had some employers that we could sock it to, but we don't. So what they did was they said, okay, well, we'll actually take on risk. And so they went to the local Louisiana Blue Cross plan. And for all the Medicare Advantage patients, they said, look, Blue Cross Louisiana, you just write us a check for the year for the Medicare Advantage beneficiary, and we'll take on all the risk. And what they did is they moved all of the care from inside of the hospital and reactive to outside of the hospital. They did home visits, they opened more community clinics, they did more outreach. And guess what they did? They actually prevented people from getting sick and having to come into the hospital in the first place. And as a result of that, they actually made $100 million of profit off of those Medicare Advantage beneficiaries, such that Ochsner is now in financial great shape because instead of being reactive fee for service complex care that loses money on Medicare and Medicaid patients, they did proactive preventative care where they were taking risk and it worked out great. And so essentially, that is a model for you need to have a forcing function for hospitals in America so that they actually follow the Ochsner model. And if employers still keep writing checks to hospitals, they won't do it, which is part of the reason why I'm giving this presentation. So we can spread the word. Employers are actually the fulcrum for healthcare change in America. So with that, I'll end it. That was a fantastic question by you. You've been a fantastic audience. You can follow me on LinkedIn, or you can go to AHealthcareZ on YouTube to watch the videos. But Heath and 6 Degrees, thank you so much for having me.
It's fantastic having you on again. Really enjoyed this conversation. So look forward to getting you back here, next year perhaps. But for next month, we've got Scotty Campbell of Self Partner Group. It's going to be on April 15th. Join us for that one. And Dr. Bricker, we're at the top of the hour. Thank you very much. Look forward to watching your Healthcare Z and all the fun stuff that you put on the internet. So thanks for doing that and keeping us all abreast of what's going on out there. Take care, everybody.
Thanks, sir. Bye now.